Okay, guys, so we have 2 minutes before we started. Let me say hi to all of you again. Let me see. So after almost 3 months, we're still here. That's a good news. Let's see how many, we have 55 people already here. You know, one thing for sure, I do know, I see two people that are always here, that's Andin and Ji Helen. So those two very, really good students, you can tell. Especially Andin with me for the past over 10 years. It's been a long time, right, Andin? All right, guys, let me go ahead and start it today lecture. And I hope by far, many of you have learned how to talk to a patient effectively. Today, we'll talk about joint pain, but at the end of this section, hopefully you can talk more, not just about joint pain, but anything that relate to a joint pain. Okay. All right, so before I start, let me share with you some good news. To me, it's super excited news. So here is the picture. Does anyone know where it is? So this is in Hanoi. I was there last week. And the embassy and VietMD thinking, do we have enough time to set up a meeting? Unfortunately, it's not because I was Vietnam in just for a few days. And then I rushed out Vietnam. But hopefully next time, Andin or Chị Helen or any of the instructor here can come to Vietnam. But guys, a couple of updates about this course. I think after finishing this class, we will create an alumni club for you guys. Because after this class, we'd like you to continue to improve your medical English. To us, it's just a waste of time and energy for all the instructor here if you stop learning. And I don't believe you will stop right there, right? All of you will continue to practice medical English. And some days go even beyond, go to conference, go to activity that not just medical English. And hopefully in the future, we will collaborate with other institutions in Hanoi and even further to continue to improve your medical English. So stay tuned with us about the alumni club. And I'd like you to feel proud someday when you graduate from this class. All right. Now, I have no disclosure for this particular lecture, no interest conflicts. So for this joint pain, I'd like you to understand a basic pathophysiology of joint pain and able to list common cause of joint pain. You learn how to examine a major joints and then understand basic management of joint pain. And lastly, learn how to practice common question regarding joint pain. If the patient comes to show, hey, doctor, I have a joint problem, what do you do? Let's see. All right. The key thing for this lecture is joint pain may arise for many reasons, with many conditions, and can have many complications. I'd like you to think about joint pain like a whole picture. It's not just a joint, it's a part of the body. So joint pain can and could lead to many bad sequences. A good history will guide to a correct diagnosis. You all know this, but how to get good history in medical English? Practicing. I told everyone from day one, the best way for you to learn medical English is to practice. And that's why we devote the majority of time here, like almost 2 hours just to practice. And that's why we want you to talk. We want you to talk to our TA, to us, to improve your medical English. Now, clinical exam plays an important role to establish the diagnosis as well as the differential diagnosis in joint pain. I do know that This is 2023, and we have a lot of advanced technology, a lot of things that you can do. Really cool. Look at your iPad and see what it is in the joint fusion. But please take a look at the patient joint, because when you feel it, you may have a better understanding what's happening. And lastly, imaging lab to confirm the diagnosis. You do not use imaging or lab just to provide diagnosis, because we are treating people. We do not treat numbers. All right, so here's some terminology that I like to share with you. The arthralgia, this is a joint pain without inflammation, versus arthritis. So arthritis is the term that includes both joint pain and inflammations. Now, inflammation, you do know that the redness, that's the and swelling. Let me see if I can see my screen here better. Okay, good. Bursitis is the inflammation of the bursa. Enthesitis, the inflammation of the enthesis. And for those of you who don't know what is the enthesis, this connection between a tendon to the bone. And tendonitis is inflammation of the tendons. And osteophyte, bony spurt. And you will use this terminology a lot whenever you talk about joint pain. If we were talking about one, we do mono. If 2 to 4, we do oligo. And then multiple, we use polyarticular joint. So monoarticular, oligoarticular, or polyarticular. So polyarthritis, monoarthritis. So those are the terms that I like you to practice. All right, so this is a picture of the knee, and this is so common called knee osteoarthritis. I just want to show you how complex or simple, depending on how you look. To me, this is very complex because I see disease everywhere when I see a knee, from the skin up to the bone and to the tendons, to the vessel behind, everywhere can cause a knee pain, not just a joint. All right, now you remember pain arrives from the structure inside the joint we call intra-articular, such as joint capsule. The periosteum, this is the around osteum, the outer layer of the bone, ligaments, subchondral bone, or synoviums. So those are the things that can cause pain from inside. However, all the things can cause pain, like inflammatory, rheumatoid arthritis, gout infections, or non-inflammatory such as osteoarthritis or trauma. Pain or joint pain can also arise from structure outside the joint, such as bursitis, tendinitis, or some weird thing called fibromyalgia. And lastly, referral pain. Now you can see joint pain can arise from many directions, from inside the joint, within the joint, or from outside the joint. So your job as provider, when you see a patient, you ask those questions, which we will practice at the end, to distinguish whether the pain comes from inside or from outside the joint. Okay, how about one single joint? What causes joint pain? Now, I list some of the reasons why one single joint can feel painful. But remember, this is just a few, not include everything. Trauma is a very common one. Overuse, we have fracture, we have bleeding into the joint, internal degradement, we call meniscal tear. Infections or septic arthritis, we have bacterial, we have fungal, we have virus. So anything can infect the joint can cause joint pain. Reactive arthritis, anything that cause infection, trauma, and then a few weeks later, you feel joint pain. Osteoarthritis. Now remember, osteoarthritis could be oligo, could be multiple joint pain, not just single one. And then we have crystal-induced arthritis. This is a new name for gout or pseudo-gout. In this lecture, you will hear I say crystal-induced arthritis in exchange to gout many times. Periarticular syndrome, like bursitis, we mentioned earlier. Cancer can cause joint pain for sure. Paget disease, avascular necrosis, and other. Now, you look at this list for one particular joint pain, you realize that many reasons may cause a joint pain by one single joint. You see this, right? Okay, how about multiple joint, oligo or polyarticular joint problem? Whenever you see more joint pain, more joints, your question would be, is there a systemic problem? Because whenever systemic problems such as rheumatoid arthritis or lupus arthritis may impact multiple joint pain. And also a viral infection systemically, the whole body can easily cause joint pain to multiple locations. Now, let me stop one right here to make sure everyone not sleeping. Let's see who is sleeping at the moment. Okay. So far, so good. Everyone listening well so far? Well, perhaps you can tell I have a lot of sweat on my face because my AC, oh my God, doesn't work here. California, extremely hot. I don't know where. Chị Helen, you okay with, but my AC for some reason it's not working at the moment. Anyway, let me continue, make sure that you can hear me clearly. All right, let's move on to non-inflammatory. So we talk about systemic right now. What happened to joint pain that have nothing to do with inflammations? Now, remember, this is the key question when you ask patient, is your joint pain worsening with or without motion? This is one of the most important questions when you ask your patient. Because if this pain is non-inflammatory, such as also osteoarthritis, this pain usually happens only with motion. If you think about it, so what is osteoarthritis? Is people call normal wear and tear, right? But actually, it's degenerative of the cartilage protective bone. So if there is degeneration of the cartilage, when you sit or the patient sit in the normal positions, they will not feel pain. However, the moment they stand up, they feel pain. This is why you ask patients sit down, they have no pain at all. But when they stand up, when they walk, the bone compression on bone, that's why they have pain. So this is the key question. Is your pain worsening with action, with motions? Now, remember, some patients with advanced OA, such as hip or knee, they still have pain at rest because the gravity stress of the bone of the articular of the hip press on the bone itself, because remember the cartilage protection worn up already. That's why they're in pain at night. How about inflammatory, like rheumatoid arthritis? Inflammatory pain with or without motion. So pain no matter what, they're always in pain. Even they're sitting, they're still pain, and even they move, they're still having pain. So that's the big difference. And then remember, inflammatory such as rheumatoid arthritis, the pain worsening at the beginning, but they slowly getting better when the patient move. So that's the key difference. Non-inflammatory, the more they move, the more pain the patient may have. All right. Another question that you will practicing to ask at the end of this section is stiffness. You want to ask about stiffness and swelling because this is the key to distinguish from many diseases. For example, the duration of the stiffness may tell you whether this is inflammatory or this is non-inflammatory. For example, non-inflammatory, not very long. They stiff for a few minutes. Rarely they stiff more than half an hour or 1 hour. In rheumatoid arthritis, for example, patient stiffness may last up to half an hour or sometimes an hour. If you think about it, the autoimmune disease is always there. the antibody, the inflammation always there. That's why the stiffness lasts longer versus non-inflammatory, the stiffness won't last that long. Range of motion is another key term that you want to ask. In fact, all of your student or resident, or even fellow, when you examine a patient, make sure you measure range of motion. Now, the best way to ask or to check patient range of motion is to check the normal one. Okay, so if you have patient two joint and one of them joint painful, you can see the other range of motion. Is that still good and the other one not good? You can compare. Now, make sure that you look at the normal exam, the normal side first. Don't go to the side with joint pain. Look at the range of motion from the normal side first. Usually, limited range of motion due to structural damage, inflammation, or contraction of the surrounding structure. Limited range of motion will and can have a strong impact on patient quality of life. Think about it. If your leg or your hand cannot move as far as you used to, for example, my hand limit like this or this, I cannot do many things, right? I cannot even put in my throat. So range of motion is the key thing you want to ask patient, how did or how well you can move your arms, your leg, your back because of joint pain. Now, muscle strength diminish as a result of muscle atrophy, and it's related to range of motion, because if range of motion limited for a long time, the muscle likely to become weaker and weaker. And weakness is a sign of chronic fatigue and a sign of chronic inflammation or problem with the joint pain. So now we talk about many things that we ask in the exam. Let's look at the patterns of joint, because the onset, duration, and pattern of symptom can guide to diagnosis. For example, if this joint pain comes suddenly, it comes in a few minutes or seconds, then this is likely a trauma, infection, or crystal-induced arthritis, such as gout. Now, if the pain is less than 6 weeks, we consider this an acute pain, and chronic is more than 6 weeks. If you look at the patterns, symmetric joint, like both sides, versus asymmetric joint, one side, you can tell whether this is involved systemic disease or not. And what systemic disease we're thinking? We have rheumatoid arthritis, we have lupus, we have those systemic joint problems that impact almost every joint. And that's why the joint pain equally both sides, versus the other one, like psoriasis or reactive or even Lyme disease, they usually one side, not both sides. In this picture, you can see the pattern of the joint pain of rheumatoid. You can see that in the proximal position here, we call this is MCP right here and PCP. You will see that toward the base of the finger and then the middle of the hand. Compared to osteoarthritis, you can see the joint pattern is out here, not inside the hand. So this is one of the basic distinguish between osteoarthritis of the hand versus rheumatoid arthritis of the hand. Again, you can see the pattern, right? Further out there is osteo, further inside is rheumatoid. Does it make sense? So look at the pattern alone, you can tell what diagnosis likely based on the patterns. And if you pay attention enough, you will see that this particular CMT joint usually quite typical for osteoarthritis, versus here it's more on the metacarpal joint pain right here. All right, now systemic involvement of the joint usually involve constitutional symptoms. So constitutional means what? Whole body. You have fever, you have shortness of breath, you have weight loss, and those suggest something systemic involved. And you want to do more workup. You don't just focus on the joint. whenever you see those symptoms, common joint pain, that's a serious sign. And you really want to focus more deeper, see why patient have fever, why patient have weight loss. Skin problems, common joint pain also suggest systemic disease, such as whenever you have psoriatic flag or redness, scaly inside or close to the joint, you think about psoriatic arthritis. Eye problems, rheumatoid arthritis, ankylosing spondylitis. So those are the problems that have systemic involved, not just the joint. So in this summary, I give you a stronger list or a longer list of differential diagnosis. You have infections, you have multiple bacterial, you have gout, you have sarcoidosis, and you have some of them very rare, such as amyloidosis. It's funny thing that not so many years ago, I saw a joint problems due to amyloidosis. And you know, how did we make diagnosis? Actually, it's by biopsy. That's a very cool case. But to tell you that many cases, the most common reason come first, and you don't go directly to amyloidosis as a cause of joint pain. Think about something very common. Now, in the other hand, non-inflammatory, you have osteoarthritis. It is so common. It is almost happening every single visit. And then osteonecrosis. Now, a very rare one, again, sarcoidosis or amyloidosis. How about multiple joint pain? So in this list, those are the common reasons why. For example, acute viral infection, rheumatoid, lupus, and the other one, very uncommon, acute sarcoidosis, adult onset still's disease, secondary syphilis, Whipple disease, vasculitis can also cause multiple joint pain. In this hand and on the right hand, chronic multiple joint pain. You have rheumatoid, you have lupus again, you have gout. And one thing that people may miss, actually, drug-induced lupus can cause joint pain also. So this is, and I will upload this lecture to the Facebook group, and I think I should have uploaded this earlier so you have some time to look at the lecture. All right. So whenever you see a patient with joint pain, you want to do a focus MSK exam beside general exam. Okay, so you don't skip the general exam. You do exam just like a normal patient, but you want to focus more on the musculoskeletal component of that examination. It usually comes with general observation, vital sign, body gesture, and sitting position. Those are the key things that whenever a patient comes to see me, I observe the patient from the day they walk to the door, how they sit down, how they stand up, how they walk. That can tell me what happened to the joint pain. For example, people with severe joint, they cannot or they unlikely to walk normal. And by looking at their body gesture, you can tell right away whether the hip, was it a knee, or whether it's ankle pain. So immediately in your mind, you have your differential diagnosis. And the way that they walk, they can also tell you that's not trauma, it's likely gout. This is likely rheumatoid. So a lot just by observation. Whenever you examine joint, make sure you follow the inspection, you palpate the joint, make sure you feel it. I told my resident or fellow, make sure you feel the joint, because some don't feel the joint, we miss some acute finding. For example, infection or gout or rheumatoid, they feel differently. Even they all feel hot. You don't tell me this is hot. No, you feel them and you can tell the difference of hotness of each type of joint pain. You want to make sure the joint and also the surrounding around the joint, okay? The skin, the nail, even the ear and the mouth, because they're all related. Now, I'd like to show you this picture to show you how beautiful a joint can live with a muscle. Whenever you see a knee joint pain, you want to make sure you examine and you feel systemically. And I told my resident or my fellow, whenever you palpate, make sure you palpate from top to the bottom, from left to right, and from to the back. Make sure you don't miss any part of the knee. All right, so here are some common exam signs that you don't want to miss. The first one is if you feel red, tender, hot effusion. This is, think about inflammation, think about infections, and those are the things that you want to do for the workup. You don't want to miss a septic arthritis that can become sepsis, and the patient may go into sepsis because you miss that. Swelling or ecchymosis suggests fracture or ligament problems. Laxity or gross deformity suggests tendon and muscle damage. And crepitus suggests derailment of the bone or meniscal side. Remember, if you one thing you remember from this lecture, anything warm, red, swollen joint, subject acute infection, and you have to do further workup. That's one thing that they call me in the middle of the night. I send my resident or my fellow to the ED right away, because those are danger signs that we don't want to miss. Because if you miss that infection, it can go further. The patient may have sepsis. All right. So here are some of the things that people present with multiple joint pain, and those are the findings versus their possible cause. And I list here for your reference. Don't worry, I will upload this lecture for you, okay, if you don't see or you cannot take note. Let's talk about labs in joint pain. Labs rarely provide a diagnosis. This is one of the misperceptions about lab, especially for medical students, even resident, fellow unlikely, because you know this. ESR CRP suggests inflammation. Yes, but they won't tell you a specific diagnosis. They won't tell you whether gout or this is RA or lupus. You really need to want to see a patient. You want to examine the patient, got a good history in order to think what it is. Could be gout, could be rheumatoid, or could be lupus. ANA, SSA, SSB, double-stranded DNA, those are very sensitive tests, but low specificity. Again, you need history and exam to come with diagnosis. You treat the patient, not the number. Okay, this is the key thing that I like to tell my residents, and I hope you remember. You treat the patient, not treat the number. All right, arthrocentesis is a very simple procedure that I ask my residents to do all the time. Basically, you aspirate a little bit fluid from the joint, and you learn so much from the joint. Whenever you see a warm, swollen effusion, you need to aspirate the fluid immediately, and you should send for cell count, culture, and crystal study. So these three things can tell you a lot about the joint, whether that infection, what type of bacterial, or whether that's a gout or pseudo-gout. So 3 things at the minimum. You can do more, but 3 things: cell count, culture, and crystal. This is a synovial fluid analysis, and this is for your reference. But basically, the way it looks is clear, transparent, and you see very few white blood cells. I tell my resident, if you look at, you can see my name tag behind a synovial fluid. That would be okay. If you don't see it, that's usually a problem. And if you don't see anything, that's a major problem. Now, remember, if you do a traumatized arthrocentesis, you likely damage the joint, and that's why you see some blood, and that's not good either. Imaging. X-ray remains the screening tool of bony abnormalities such as fracture, effusion. CT you use for bony trauma, or the patient is not compatible with MRI. Now, ultrasound is used a lot. I use ultrasound almost like in every day in my practice, and I'm sure you see it a lot. Ultrasound gives you instantaneous result of the effusion, synovitis, and also fracture. So it's very easy to learn, and it's so accessible. Lastly, MRI provides a better image of all bone tendons and internal structure with a higher cost. Of course, if I want image, I want MRI of everything, but unfortunately, MRI is so expensive, especially in Vietnam. So make sure you use each modality differently and appropriately. Let's finish with the management here. We start with non-pharmacological therapy. Make sure that you use rate treatment, so rest, ice, compression, elevation. Physical therapy remain one of the best one to treat joint pain. Massage therapy, aqua therapy. Pharmacology, medication-wise, you NSAID versus AP, Tylenol. Topicals. Topicals, the one that you learn a lot, but you don't use a lot. I will tell you, a lot of residents or even fellows don't know that we have so many topical for joint pain nowadays. At least 10. So think about it. There's a lot of topical you can apply, and they have minimal side effect compared to systemic medication. I repeat, I rarely use opioid for joint pain, especially for osteoarthritis, unless this joint pain has cancer association or anything that non-respond to conventional treatment, then I use opioid. SSRI for depression, anxiety actually could be a good medication for chronic joint pain. And once you fail many of those, you can think of SSRI. Behavioral therapy is another component of joint pain that you don't want to miss. Talk about patient lifestyle, how they walk, how they use the joint. Change their lifestyle can make a big difference in terms of their joint pain. Diet, fall prevention, and you move up to this ladder here. You have intervention, injection steroid versus hyaluronic acid. You can do slinging, you do casting, anything that can make the joint slowly improve. And lastly, surgery, we have total joint replacement. So I give you a quick list here of treatment of septic joint with a gout, muscle spasm, and you can use this for your practice. So here are the 9 practice questions that we are going to ask you, and also the TA, they give you a couple more questions to ask, but make sure you ask a lot, make sure you practice a lot. Where is your pain? Because that can tell you whether mono versus poly, one joint or multiple joint. How does the pain feel like? Remember, patient pain is different from your pain. Sometimes you have a different perspective about pain compared to a patient. So ask their perspective, don't use your perspective. How long you have this joint pain? Do you have morning stiffness for how long? Have your joint ever been injured? Because if someone have an injury joint pain, the patient likely to have or develop some other problem than a normal person. Are you taking any medication, any new medication lately? Have you traveled? Have you been sick lately? What activity you cannot do due to this joint pain? So those are the basic questions that you want to ask patients regarding joint pain. And I will stop my lecture right here, and let's see. Wow, it's about time, half an hour. And any questions so far? Are you still all awake or you all sleep? Okay. Yes, go ahead, number 31.
Hello, Dr. Wynn Tran, and hello, all the teacher and our student. Okay, I have a question for you. I work in department of joint pain, of joint disease, in my hospital. This is the hospital of security public. So every day we use traditional medicine to cure joint pain, and it works. It has its own efficiency. And I didn't see you mention any traditional medicine in your lecture, like for example, like acupuncture or herbs or other kinds of methods. So can you tell me please, like in America, how people use traditional med to cure this disease? Thank you.
Great question. Well, let's put it this way. When I prepared the lecture, the target audience actually it's senior medical student or first year or second year intern. And I don't want to put so many information, but you're right. I I think we call alternative medicine in the US, alternative and complement medicine, which is the one you just mentioned, acupuncture. So it's covered to several aspects. First of all, insurance may not pay. This is something that I usually come talk to my patient because as attending physician, some insurance they pay, some they may not pay. But regarding effectiveness, it depends a lot on the operator. For example, if you have a good massage therapist, the result could be better than a non-experienced one. But my general recommendation is yes, if the patient want to try, we will refer the patient to acupuncture or massage therapy for sure. But in terms of, they're not conventional medicine, but they consider alternative medicine, and some insurance they will pay, some they won't pay. In fact, there are a few weeks ago, actually, one of the conference that I attend spent the whole day to review all the modalities, and it's very interesting to see that some of them very effective. Acupuncture is one of them, so you mentioned that. And the other one that some people, they also use coining, they use some traditional medicine for joint pain, and the result is some of them are really good. All right. Anything else, guys? And then I'm still around here in this lecture, so we'll go to the smaller room, the breakout rooms, and we will spend a lot of time with our TA. And you guys, this is your time. I want you to really spend time to talk. The reason we bring so many TAs, so many instructors to this course, and in the future, you even see more, because VMD is recruiting newer instructor, also other helper, to make sure you guys have enough practice. So talk to me, talk to my TAs, talk to anyone about anything. Well, let's focus on joint pain today. All right, and we'll go from there.